Whenever I look at patients with lower back and pelvic pain, I'll always do what I call a screening test for the foot, the ankle, the knee and the hip. And this is prior to my assessment on the lumbar spine. Why? Because any pathology in the lower limb is going to give you a compensation potential for pain to that sort of area of the body. So I normally start off with the great toe. The great toe medically is known as the hallux. And we are looking for almost like a simple range of motion. We're looking for great toe extension of at least 45 degrees passively in here. So if you've got a condition, say hallux rigidus or hallux valgus, or even like on men can have something called gout, then that might cause a limitation of that movement. And then that will affect you, especially going through the gait cycle. So when you're in the mid stance and then you go into heel lift, toe off, etc., and then you basically will need that range of motion. If you cannot extend through the great toe, it's going to compensate through the other toes. The next is the ankle, which is the talocrural joint. So from here, so I normally typically come to about 90 degrees. I'm looking for at least 10 degrees of dorsiflexion coming through the talocrural joint. And again, if we have limited movement within the talocrural, then more than likely the subtalar joint will compensate for that. The knee, I would look for full extension. So I'd hold the lower limb, hold the thigh, and I slowly passively extend to make sure we got full extension. If we needed to, obviously compare on the other side. Okay, and then from there I would flex the knee. So make sure that we got full flexion of the knee and then full extension of the knee. Obviously we would do both sides. If that's okay, you know, if we got like a meniscal tear to the knee or we've got degenerative changes to the knee, then that will affect obviously the lower limb and also the upper limb in terms of the pelvic and even further up into the thoracic spine and the cervical spine. So it's amazing that a problem within this area in here can generate symptoms in other areas of the body. Moving on to the hip joint. So from here, I would place them into what we call the 90-90 position. So 90 degrees of hip flexion, 90 degrees of knee flexion. The first movement I would look for about 45 degrees of external rotation. Okay, and we can see that we have good range of motion here. Then I move on to internal rotation. We're looking for about 30-35 degrees with no real restriction. If we have a restriction, it could be many things. One of them being an arthritic change to the hip joint. Could also be things like a cam lesion or even a labral tear within. From here, I would take the foot across the opposite leg and allow that leg to drop down. This is called the Faber's test, which is flexion, abduction, external rotation. It's hard to know what's normal because it's comparative to the opposite side. But in theory, this would be a normal range of motion testing. I can take it into full flexion to make sure there's no issue within flexion within the joint. And then from there, I'm going to do what we call a fair test, which is known as flexion, adduction, internal rotation. So within flexion, so I would take into adduction and then I would slowly internally rotate. If the patient feels any symptoms directly within the groin area, then this might be a positive sign, if you like, for any type of impingement, which could be coming from what we call an FAI, femoral acetabular impingement, for instance, like a cam or pincer lesion, or also a labral tear. So just bear that in mind, and remember it's comparative. So these will be my screening tests for the foot, including the great toe and the ankle, the knee, and then finally to the hip. And remember, this is done prior to looking at the pelvis or the lumbar spine. Thank you for watching.